It's not there.
So thank you, Gail. I would now, given that we have talked about global health, Africa, non-pharmaceutical interventions from Gail's research body of work over the last 2 decades, I will now turn to Nina to share her thoughts on pharmaceutical and findings from pharmaceutical procurement in China. Nina, over to you.
Okay. Can you see my screen?
Yeah, it's coming slowly. Yeah, it came.
Is it okay? Okay. Okay. Good afternoon, everyone. It's my great pleasure to share my recent study with my co-authors. And here I'd like to thank for Toronto's invitation and also the organization of IHOPE. Okay, so today the topics of my presentation is about has the shortened drug distribution chain cut drug prices, evidence from the implementation of a two-invoice system in China. Okay, so as we all know that China has faced a fast aging process with more than 18% of aged population in 2020. And as forecast by WHO, these figures will be increased to 28% in 2040. And aging has posed significant challenges to the whole society and especially for the healthcare expenditure. And as for the national health insurance expenditure, the total spending has been increased by 5 times from 10 years, from 2010 to 2020. And the drug expenditure has been a huge part among the total medical cost. And for example, in 2009, it accounts for over 50% of the outpatient medical cost and 43% of the inpatient medical cost. And therefore, to constrain the inflated drug prices, government regulators has implemented a series of reforms in pharmaceutical distribution sector in China. It includes zero markup policies in 2012 and two-invoice systems in 2016 and volume-based procurement policy in 2019. And now today, we're going to discuss more details about the two-invoice system. Well, another reason that we are interested in this topic is because that, as we all know, that the healthcare market is characterized as with full of uncertainty, with information asymmetry, and also externalities. And therefore, the government intervention has played a very important role in shaping the market outcome. And it includes national insurance provisions, entry authorizations, and cost control, etc. In terms of the cost control plans, there are many different types of measures has been adopted in the global communities, including the generic compulsory substitutions in the US and also the reference pricing in the Europe. Well, it's always been an intriguing question about how effective this type of government policy is implemented. And China's government is also very well known for its regulatory power and fast enforcement. And therefore, we are very interested in how this policy being implemented. Well, before we discuss about the impact of the policy, let's first have a look at what this policy is. Okay, so as shown in this figure, we know that before the two-invoice system, the China's distribution sector has been characterized as a multi-layered wholesaler system, which means that when the drug comes out from the manufacturers, it will go through the primary wholesalers at a national level, and towards the provincial level wholesalers and etc., and then to some city or county level wholesalers. And in total, there are like more than 3 to 5 layers of the distributors along the supply chain. And after each distributor, there will be one invoice being issued. And now, after the two invoice system, the government required that only 2 invoices be issued. Okay, so which compulsorily restrict the whole supply chain would become a single layer of wholesalers. And therefore, the whole distribution channel becomes transparency. And we can trace the whole source of the drugs and also the ex-factory prices, etc. And therefore, it kind of turns out that the high markup systems before the 2 invoice system has been greatly decreased because of the transparency of the distribution chain. And therefore, we observe the compression of intermediate profits, compression of distribution channel, and also some exit of small and medium-sized distribution firms. Okay, so at the first glance, we would have the impression that after the implementation of 2 invoice system, the drug prices should be greatly reduced because of the reduced of transaction cost during the supply chain. However, it may not be the case because China's varied geographic regions and there are many mountain areas and remote areas, and in that case, a single layer of wholesalers may not be successfully fulfill the whole delivery tasks for the whole system. Okay. Therefore, in our study, we are trying to investigate how effective the 2 invoice system is implemented and what's the influence on the firm's selling behaviors. Well, from this timeline, it shows that the schedule of the 2 invoice system is implemented across time for different provinces. And we can see that the TIS implemented gradually across provinces from 2014 to 2018, and with a trial implementation in Fujian and Qinghai and Anhui. And after that, a nationwide promotion is initiated in January 2017. And the full implementation is started in 2018. Okay, so this map shows the timing of different provinces that has initiated the TIS, and the variation of the different schedule across provinces provided us a very good experiment to disentangle the causal effect of the policy implementation with the difference method. Okay, so as for the literature review, we have already seen that there's a large portion of drug sales revenue is captured by the distributors in the supply chain system. And especially in China, we found that the commercial promotion and bribery activities are quite often in the distribution sector. And also there are some US studies show that improving the distribution system may serve to control the drug price. Well, in terms of the impact of the TIS, there are some price effect studies that shows after the implementation of the TIS, we found that the ex-factory price increases and the retail prices decrease. However, there are 15% of the sales managers disagree with the price decrease effect. Okay. And there are also some other effects related to the innovations or the selling expenses, etc. Well, now for the preview of our study of the result, well, we found that the introduction of the TIS slightly increased the drug prices by 1.4% on average in a nationwide. It is mainly driven by price changes in the underdeveloped area. And we also found that, well, the selling expenses for the listed pharmaceutical manufacturers increased on average by 193 billion RMB, and the share of selling expenses on sales revenue also rise by 0.223. And we also found that the operation margins reduced by 2.34 percentage point. So why this happens? Well, because we know that the underdeveloped areas are mainly refers to those mountain areas or remote areas with less developed transportation system. Therefore, the whole delivery cost could be high. And after reduced total supply chain, it might be the case that the most efficiently distributors could be removed from market because they can't supply the whole nation. And in that case, it might result in some efficiency loss. And also, on the other hand, because of the transparency of the distribution sector, the selling activities, which originally normally happened in the distribution sectors, now has to be removed from this supply chain because of the transparency of the drug price. Therefore, the selling expenses has been moved upward to the pharmaceutical manufacturer. Okay, so the contribution. In our study, we construct a model to characterize the manufacturers and the retailers' decision makings on prices and promotion behaviors. And we also provide the first nationwide evidences. And the two invoice system didn't lower down the drug prices. And we suggest that it is because the underlying reasons behind the phenomenon of prescription rebates has not been addressed. Therefore, this type of bribery activities may happen elsewhere, and the patient will continue to pay for it. Okay. Now, the data. To conduct this study, we collected data from two main sources. One is from Yaozi database, which provides the firm-specific drug procurement prices at the provincial level. And we also collected data from one database that includes financial data of A-shared listed firms. And we focused on the pharmaceutical firms, medical device firms, and API firms. Okay. And we turn our focus to the chemical drugs and exclude combinations, and the formulation is restricted to pills and capsules. And to compare the whole effect of the implementation of TIS, we kind of have to keep only those samples with products and producers before and after the TIS. Okay, in that way, we got around 235 active ingredients, 761 producers, and even more observation numbers. Okay, so this is the summary statistics for our study. And we kind of observe the unit price of the drugs and the population of each province, the GDP of each province, and the dependency ratio, listed firms' total revenue, and the time of the TIS introduction, and also the either this observation is treated by the policy or not, and the number of competitors for the drug, etc. Okay, so for this study, as we introduced before, since the policy is implemented in a gradual way, so therefore we try to adopt a staggered difference in difference method to disentangle this causal effect. And we follow the two-way fixed effect model to estimate the parameters. So as we show in this equation 1, so the y variable denoted the logged procurement price of drug I produced by firm J in province P and month N. And then we included some producer product, province strength formulation fixed effect, peer fixed effect, and also a dummy for the TIS introduction in province P and month N, and some error. Okay, so with this model, we can see our baseline result. So we try to use 3 different data to indicate the implementation of the TIS. So the first is the announcement of TIS. Then the introduction, the initial date of introducing the policy in this province as a trial. And then the completion date, which means that for the whole province, the policy has been totally implemented. And then we can see that for our result, the second variable shows a significant and positive effect, which means that only when the TIS is introduced in this province, it can have some significant and positive effect on the drug price. Okay. And after we include both 3 variables, and also the second one is significant and positive. And then we conduct some event studies to show whether there's some trend. And we can add if the group and the treatment zero, and after the population, we also do some alternative estimators by estimator, because in model the two-way fix may have some treatment effect. Is two-way fix treatment effect across time, JF, to disentangle this type of heterogeneity. And then after that, the parallel trend become more obvious that after the trade policy implementation, we saw that the price effect will be higher. Okay. So this is the estimator for two-way fixed effect, Woodridge, and BJS. And we can see the point estimate about the price effect are all significant and positive. Okay. And then we do some heterogeneity analysis to divide the sample as developed area and underdeveloped area. So the developed areas are include the GDP top 10 provinces plus 4 municipalities, cities, and the rest provinces are the underdeveloped area. And we can see that for the developed area, except the two-way fixed effect estimator, all the else estimator are insignificant and across to zero effect. But for the underdeveloped area, both all the 3 estimators are significant and positive, which indicated that the price effect mainly happens in the underdeveloped areas, where the with remoted and mountain regions, and the transportation cost could be quite high, and therefore this compulsory reduced supply chain may result in some inefficiency. Okay. So now in the lecture, we try to investigate the impact of the TIS on the selling behaviors of pharmaceutical firms. To investigate this question, we adopt a standard difference in difference method to explore how the 2 invoice system affects the A-shared list of pharmaceutical firms' financial performance. So we choose the pharmaceutical firms as a treatment group, and all the API and medical device firms, as these firms are not subject to the policy. So we treat it as a control group. And we use the policy year 2016 as a dummy. And so since the firms are sales across different provinces. Therefore, in this case, we cannot use a staggered DID. Okay, so here's the model, which is similar to the previous one. And then we got the result. We can see that after the implementation of two invoice system, the selling expenses of pharmaceutical manufacturers increase. And also the selling expense over the total revenue is also increased. However, the operation margin of the firms is decreased. It suggests that after the two TIS, we can see that there are more selling activities are conducted at the manufacturer side. However, this might not be efficient because their margin might be reduced. Okay. We also consider some other confounding effect from other reforms, and our results show that the previous baseline model has been robust. And then there's some placebo test also shows that our effect is stable. Then conclusion, we developed a series. Because of time, due to the time constraint, I omitted the theoretical model. But if you are interested in, we can share it later with our paper. So conclusion, in our paper, making of drug prices and bribery activities for manufacturers and retailers. And we also adopt staggered DID model to in detail the firm-specific drug procurement prices data. Both two-way fixed effect and other robust estimators suggest that the TIS slightly increased drug prices mildly. Find that after TIS, drug firms' selling expenses increase and operation margins decrease. It suggests that the bribery for prescription activities move upward to the manufacturer side. Okay, so that's all for my presentation. Thank you.
Thank you, Nina. You're bang on time. A fascinating policy experiment. I have left on the chat window a McKinsey report on the two invoice system in China, which I think is one of its kind in the world. And another demonstration of how something noble meant for patient welfare can have its own unintended consequences. So from the non-pharma interventions world of GAIL and the two invoice system in China, we now move to Samarth, who is there in the room, and he's going to now talk about pharmaceutical procurement and price spillover effects in developing economies. Samarth, can you hear me?
Yeah, I can hear you, Jonathan. I'm waiting for the slides.
Disclosure, this is a joint project. Samarth and me have been working for some time on this project, and yeah, all mistakes, responsibilities, Samarth. All plaudits, I can take the plaudits.
Jonathan will ask. Okay. All right. Thank you, everyone. Thank you for the invitation. My name is Samarth. I am an assistant professor of economics at Ahmedabad University. So I'll be talking about public pharmacy programs and specifically their impact or their spillover on the private sector. So both these components of the entire market of public of pharmacies. My objective here is to, of course, introduce the research that Chirantan and I have conducted, the case of West Bengal in India, but also to develop an agenda for research in this sphere, in the sphere of public pharmacies, and what are the questions that one could develop to evaluate the framework. Okay, public provision of these pharmaceutical goods is actually quite common. The citations that you see are from across the world. So they are especially in developing countries in South America, Chile, Guatemala, China, one case you just saw. And in India as well. Of course, different states by themselves have very different models. But the government of India is perhaps running one of the largest public pharmacy programs through Jan Aushadhi Kendras. Right? So this is something that's quite common and in India, the gaze is now developing. The gaze is now coming over these pharmaceutical interventions, these pharmacy interventions, not pharmaceutical. For example, there's this sort of anecdotal and journalistic account of how Janaushadhi pharmacies may have some of their own specific kind of problems. Right? So, and as I said, different states have their own agendas, they have their own models. What is it that we can learn from these public pharmacy stores, and what can we take from this in terms of the themes of this conference? Right. The question that we investigated in the paper was, how did the private sector respond to the introduction or entry of public pharmacies in one particular state of India? Before I go into that particular state and that case, just a few things about why private sector's role is important at all. Right. For India itself, the pharma market is big and vibrant. I think most of you would know, but one thing that struck me was that this article by Porecha 2021 suggests that there are nearly 17 brands for every drug in India. So the private sector is very active and vibrant, right? So the spillover on them needs to be accounted for. And private sector sometimes acts as a two-edged sword in markets, in education, in pharmaceutical and medical markets, because of the kind of markets that these are, right? Widespread availability of these of masks and tests during the first wave was due to an active, vibrant private sector. But we also saw that in the second wave, the extractionary greed of private sector was quite unfortunate. Right, so it's important to understand what are the drivers, what are the motives of the private sector, and how do they respond when they face this public competition. The case we are studying is the case of fair price medicine shops in India, in West Bengal, in the state of West Bengal in India. And this is a specific kind of model which is different from other public pharmacy interventions that I've seen. The first distinction is in the unique procurement model that they have. Usually what happens is there's this large state-owned firm trying to leverage its bargaining power and gain volume discounts. Here, the West Bengal government decided to outsource operation, procurement, and sale of public drugstores to private firms. These were known as fair price medicine shops. How were the prices determined, or how were these private firms selected? Through an auction process. Any private firm which bid the highest discount it was going to offer was provided the opportunity to run these stores. And as mentioned, procurement was done by these private firms themselves. No state-owned firm was there. The drugs that were available in these stores was quite a comprehensive list of. We divide them into oncology and non-oncology drugs. That will become apparent why we do that. And West Bengal government's report, anecdotal evidence, journalistic account all suggest that there was a rapid growth. There was a specific, very strong impact of FPMS operations in West Bengal. For example, the year-on-year sales growth of FPMS was nearly 100%. Whereas the sales growth of the same medicines using the AICD data appears to be only 5%. So there was a lot of shift occurring from private sector to these public pharmacies. This was the first phase till 2014. After that, there was a second phase as well. And since our data is till 2014, I don't have those numbers here. As I mentioned, we want to know what happens to prices of these drugs in private pharmacies. Right, for the reasons that I mentioned before, that private pharmacies, it's important to study them. Here's a snapshot of the result. We do a lot more. There's a lot of machinery behind all this, but the way to read this is the change in prices. So we have wholesale prices in non-oncology, retail prices in non-oncology, wholesale prices in oncology, retail prices in oncology. The change in prices in the non-oncology space was that of a downward trend. Both wholesale prices and retail prices declined after the entry of these FPMSs. So wholesale, I should mention, wholesale prices and retail prices in the private sector decline after the entry of these semi-public pharmacies. But for the oncology space in the wholesale market, at least, we see a jump. We see a really big jump of nearly 900 rupees. In the retail prices, we don't see that kind of change, a significant change. But we do see that in oncology space, a lot of these prices are capped above, and we find that many of these prices in the private retail stores were reaching their caps more and more. Right? Why is this happening? What is the hypothesis behind it? So we develop a theoretical model, and the idea here is that when a public sector enters, and this is a general idea from economics, that the first thing that happens is after the entry of a public sector is that it takes away these service agnostic consumers, right? So imagine there's a mass of consumers, some of which are service agnostic, some of which are very conscious of service and quality or perceived quality. What happens afterward? So whatever will happen to the private retailers depends on these residual consumers, what these residual consumers are like, what is their behavior like. For oncology, our hypothesis is that residual consumers are price inelastic, right? So this is very much similar to the generic competition paradox, well recorded fact in this kind of literature. So if residual consumers are price inelastic, new prices can be increased. Wholesalers observe this signal, right? So wholesalers observe that retailers are somehow aggressively procuring drugs because they now have this opportunity, and therefore wholesalers increase their price. Non-oncology space, the residual consumers are probably as price sensitive. So there is a difference in their demand for service, but not in the terms of elasticity. The old prices will make operations unviable. And what do wholesalers do? Well, they can't really let go of this weak chicken that lays some kind of golden egg. So they try to reduce their prices as well, reduce the wholesale prices, and that's what follows. We do a lot more robustness checks to justify whether what we see, what we say is actually happening. So I won't go into all those tests that we do. What I want to discuss is what is it that we can learn from this particular case regarding these public pharmacy interventions. And if we were to come up with an evaluation framework of these public pharmacy interventions, what should be the right model to do so? What are the parameters of the model that we have in mind? First is procurement. So I'll go through each and every one of them in separate slides. But should there be a large state-owned firm, which is what is the common model? And earlier today, somebody also mentioned that a specific case in the eye care industry, or could it be that there's a scope for these multiple public-private enterprises competing with each other and coming up with revealing the price by themselves? Availability, should it only have generic medicines or branded as well? Could there be a case for including branded medicines? Although almost all cases that I have come across, by construction, they only store generic drugs. Acute versus chronic drugs, could it be that we should restrict ourselves to certain kinds of drugs? Accessibility, should it be conditional on income or income levels or geography, or universal, which is exactly what happens right now? And finally, in which of these models would there be more viability for the private sector? Also, the budget balanceness of the public sector. So most public sector firms, there's this concept in IO specifically about soft budget constraints. How far can you stretch the budget for these public sector firms? So let's go through each one of these parameters of the model. And why are they important to study? So as I mentioned, most common models of public pharmacies is that of a large firm trying to procure medicines and gaining volume discounts. So for Jan Aushadhi Kendras in India, there's this Pharmaceuticals and Medical Devices Bureau of India, right? I mentioned that West Bengal has a different procurement model. The question is, which procurement model, the bigger question is, which procurement model provides more welfare gains? Because each different procurement models would have different kinds of price discovery process. So Anindya mentioned earlier on about information asymmetry, which is something very prevalent in these kind of markets. Where will do we really expect state-owned firms to come up with to reveal or discover the optimal price at which they should start bargaining, or should we leave it to the private, should we leave it to the market to come up with the price for us? Second question on availability. For that, give me some time to explain what I mean by availability under dynamics. So discounts in period 1 for this model was dependent on pre-FPMS prices and pre-FPMS MRPs. Now, private sector firms responded by changing prices. Now, in period 2, in subsequent periods, will FPMS operators be able to sustain the discounts on the new prices, right? Not on the old ones. So the initial conditions on which the model was being rolled out has changed. So how many times should we keep renegotiating the contract with the FPMS providers? On the other hand, will a state-owned, as I mentioned, will a state-owned firm be able to discover optimal market prices again and again? Right. Question on accessibility, especially under the sorting of markets. So sorting is something which is very common between public and private sector firms. Surprisingly, although most public good provisions have a condition attached that if you are below a certain income level, then you will get this particular good. But when it comes to public pharmacies, almost all cases, except for one in Chile, I found that access is quite universal. Everybody can access it. But do we really need that, given the fact that there is already sorting going on, right? Can we exploit the sorting mechanism, create conditions for access so that it allows for private sector viability as well? Right? And finally, there was the other theme of this conference has been this volume to value. And many people mentioned that value is itself difficult to define. But imagine if we could define quality as a measure or one dimension of value. Could it be that these kind of interventions actually lead to a climb down in value? Here's a quote by KL Sharma, who mentions that many suppliers of these Jan Aushadhi Kendra are not WHO GMP compliant, right? Which is not a mandatory requirement. It's not as if it's a sin. But he says that maybe there is a question of quality of these drugs. Our testable implication suggests that private sector, to ensure viability, will start reducing quality for non-oncology drugs. We don't test this. It's an extension that we would want to go into. Whereas for oncology drugs, we might see an improvement in quality, right? So that leads to these questions of which kind of medicine should be sold in public pharmacies, given the fact that we know private sector may respond in quality. I don't want to say will, because we don't have that evidence in the paper. But these are the questions or the parameters of the evaluation framework that we want to set up for public pharmacies. Thinking of it as a research agenda that we can bring to these kind of conferences. Every state in India has its own public pharmacy program. Government of India itself has its own public pharmacy programs. Is there a chance for cross learning? So these are the kind of questions that we want to go to after, given the fact that this paper is nearly at the end of its road, hopefully. So I'll leave it at this point. Any questions, please reach out to me on this email. Any questions I cannot answer, I'll guide them to Chirantan.
Thank you. Thank you very much, Samarth. I think it was a fascinating presentation. So we have come to the end of Gail's, Nina's, and Samarth's talk. And I'll turn it back to Anindya, my co-author in the room, to quickly finish the questions. I think Gail has to leave in 10 minutes for another engagement. So let's take the questions for Gail first, and then we can go to Nina and Samarth.
Yeah. So I think all three talks were fascinating, shedding light on many different dimensions. So any questions, and specifically for Gail, and then we can go to the other speakers. So in that case, I will start with a question that I had, and then later on, if you have questions, please feel free to come in. So again, you're there, right?
Yes, I'm here.
Oh, right. So I was actually very, I found it quite fascinating what you described, and then I was thinking that there are often some diseases that are not attracting enough attentions especially in the context of less developed countries. Especially the R&D expenditure is often very less on them because they are not talked about enough. And it seems like you have identified one such class of disease. So for the policymakers or for let's say the healthcare providers, is there any generalized learning that you can share with us that in case people do really identify these problems as individual researchers and scientists, how do they scale it up and how do they make it a bit more apparent to the policymakers?
Yes, thank you very much for that question. And I do believe that something of what we've learned in podocarditis is transferable to other of the more neglected conditions. And I think we thought through carefully what do policymakers need, what do implementers need, what do academics need. For policymakers, there was a need for good data. Nobody had any idea of the scale of the problem, the distribution of the problem, or the cost of the problem. And so the mapping work that I talked about, and then that, the sort of estimation of the cost of the country have been really, really important in bringing the Ethiopian Ministry of Health's attention to this condition. But then you also, you don't want to just present policymakers with a problem. You want to bring them solutions too. And so it's been really vital that we, alongside the sort of work on describing the disease, we've done the research into treatment, prevention, that sort of thing. And so the trial was very important in establishing that this very simple self-care package was effective. And then implementation research, or also called operational research, is vital. So yes, in a trial we've shown it works. Then we have done a round of operational research showing what works in real life, if you like, when a government program takes on this innovation, if you like, what happens, what works and what doesn't in real life. And so that has been the next step in terms of what we can do for patients who are affected by podocarditis. So I think all those steps are important. And then the final thing I'll add is that as well as good data, stories are important too. And so equipping affected people to tell their stories at local, regional and national level is really important. And then just having the sort of communications experts help with bringing stories and appropriate photos to the right audiences is also really powerful. Thank you.
Thanks, Gil. Any questions?
Yeah. My question is a little broader. We have all the pharmaceutical companies coming with very innovative procedures, but when these procedures come to a country like India or any lower middle income country or a global south, their prices are unaffordable to the larger population. And we cannot just come and because they are patented, we just cannot call it a public health emergency and use the WTO Doha round clauses and start making a generic drugs, something that happened in Africa with respect to AIDS. So is there any solution where we make it a win-win situation where these procedures are available to a larger population, but at the same time we somewhere ensure that pharmaceutical companies just wind up their business and go away? I mean, that they can always do. So is there any middle ground for this?
Chirantan,
do you think that question is for me?
Anyway, I mean,
I can take that question quickly. I can take that question quickly. by
Okay.
saying that you should look at my Journal of Health Economics paper, which amidst an portfolio of different strategies from firm side and policies from the health policy maker side, this seems to be the way forward, though it might be conditioned by the elasticity of the disease condition. So the paper I'm talking about is about an oral anti-diabetic drug called sitagliptin, where Merck decided to differentially price its product by itself, and that really created a large market share for that company, and we show the welfare effects of that. So differential pricing is the policy intervention I'm talking about to somewhat mitigate the affordability issue of innovative treatments and solutions launched in developing economies like India. But Merck didn't do it just like that. They also got some sort of a promise from the policymakers of the land that their patent will be respected for Januvia. But at the same time, there was an at-risk generic entry by Glenmark for this particular drug. So the point that I'm trying to say is that it's a moving frontier. Differential pricing seems to be somewhat of a solution that we may have also learned from the pandemic in other drug market and product market contexts in health. And the threat option, or an option where you go ballistic between innovators and generic companies, may not be the right counterfactual scenarios, it seems to me, from that particular context. But that's oral anti-diabetes. Things might be different in cancer, very different in asthma, very different in tuberculosis, etc., etc. So we have to really see what the evidence is telling us on the welfare effects of differential pricing in different drug market conditions.
So I think we'll have 1 minute for another question to Gil. Yeah, please.
So my specific question is for Ms. Nina. So congratulations for the wonderful study. First of all, this is how probably analysis should be done in terms of how a policy could not reach its definite purpose, and it probably went on the other side. So you mentioned that you did a difference in difference to a fixed effects model, wherein the treatment group, because of the staggered implementation of the study. My question is basically, because the ones where the policy was implemented is considered as the treated, and the ones where it is not happening is the control group. Wouldn't you find a large difference in terms of the groups in itself? Do you do some matching to cover that effect before you straight away come to the conclusion?
Well, thanks for the question. Well, for the staggered DID, we kind of treat those observations who haven't been affected by the policy as a control group. And after the time, as time goes by, if it is being treated, then it will become the treatment group. So we kind of treated every time point as different policy implementation, but we kind of aggregated this, we average all these treatment effect, and it generated a two-way fixed effect. But because this kind of treatment effect can have some heterogeneity across time, which means it might be dynamic, and in that case, the two-way fixed effect is just to average of the overall effect. It may make some may assign some weights to different time point treatment effect, different weights. Some of the weights might be negative. In that case, it's problematic. So therefore, we try to use some alternative estimator to address this issue. Okay, but we didn't do any matching for the observations. Okay.
Thanks, Nina.
May I answer your question?
Sure, thank you.
Okay.
Okay, Gail has to go. Any other questions for Gail from the audience, online or offline? If no, Gail, thanks a lot again for making time. Much appreciated.
Thank you very much. Really appreciate it.
Real pleasure. Again, thanks so much for the invitation. It's been great to join you. Bye now.
Bye-bye.
Bye.
Okay, any question for Nina and Samarth?
There is a question. Yeah.
Thank you for so nice talks. I'm actually practicing in the same area Samarth sir has done the study.
Yeah.
So I have few observations. Like when we started, this PFMS was started. So there was the other small medicine shops dried off. I work in the specific medical colleges. So only the first medical colleges were targeted. Then all other up to district hospitals, they were converted into this kind of shops and allowed with this kind of shops. Now we as doctors are not new to these kind of drugs because they were procured for the government supplies. In GM portal was not there at that point of time. However the procurement was done, the pricing was there was always a pricing differential among the marketed drugs and the drugs procured in the hospitals.
Right.
So it was made into a separate shop. So the small shops died. Now as the time progressed, the trust, we didn't have, doctors generally do not trust these generic drugs, but the trust gradually built upon because it was working. For Indian context, it is working, not all like actually subjective, but it's objective, it is working. Now something has turned up. So there are hybrid shops.
Okay.
So after this has come, this PFMS, it assures you up to 80% discount.
Yeah.
It's the tagline.
Yeah.
This is how they sell.
Yeah.
So after that, after the stockist price to the consumer price, there is 40% differential.
Okay.
So the retailers cut down from the 40%, so they are giving 25% discount, up to 25% discount.
Private retailers?
Yes, private retailers. Even the online pharmacies usually give to 18 to 25% discount.
Okay.
And now there are a hybrid kind of a shop, which actually writes over that it's a generic shop.
My friend, can you keep your question short? What is the point of your context?
So the point is that is it changing? I mean, the idea of what PFMS was started is the private market is also accommodating with that, because of the hybrid shop sells both the things, generic drugs as well as the private drug, the branded drugs, and in the same under the same shop, and it actually converts the people, the middle class people, from that generic drug to the branded drug. So it is a new thing I have seen. There are shops there.
So Chirantan, can I add a question to that?
Yeah.
Kind of building further on that. So what I was also thinking that you mentioned about price discovery.
Yeah.
And higher competition presumably leads to more price discovery and finding the true price. What I was thinking is that in case where you have very weak regulatory regimes, it's possible that during the competition to reduce price, the quality may not be kept the same.
Right. Yeah.
So that's how what are the ways to ensure that that at least quality is remaining the same, conditional on the price recovery is good. But given the fact that we are talking about all of these things to begin with because there is weak regulatory regime.
Yeah.
So what about the quality dimension? I was just curious about this. So, Chirantan, any thoughts or summary?
Let me respond to your question. First, you're right. Quality is something. So, if you read their documents, West Bengal government's document, they do mention that you have to get these kind of drugs. But we all know that there's that boundary is very flexible. That's why in the end I mentioned that there are these testable implications of our paper about quality, which we have not been able to test. It's kind of like an extension of the work that we would want to get into. Quality is, and if we read all those newspaper articles about Jan Aushadhi Kendra, quality is an issue. So that's something that we acknowledge. But other than acknowledging it, we can't really say too much. But if we look at what that gentleman over there mentioned, that initially people did not have trust, or doctors don't have trust in these generic drugs, but now over time they learned to trust them. It may seem that some kind of learning by doing has led to realization that the quality is not that bad. So maybe that answer that quality will always decline is wrong. Maybe the quality is sufficiently okay for doctors to start trusting. So that's something that's one thing I can say. Now to that question on hybrid shops we'll discuss more about this. Okay, so after that, it's an interesting observation that little shops died. And
yes, little shops died.
Yeah, we didn't mention some of the news articles which mentioned that after the FBMS entry, the smaller shops did shut down.
Yes.
So yeah. Chirantan?
Just to add, there is a broader conversation here on the philosophical normal, we should be thinking about access to public goods. So think about not just medicines, but let's say education. When right to education came in India, there was an effect in the way private education and the tutorial market adapted itself to the universalization of education in India. If you go to the US and look at when they brought in public broadband, a similar story in how private broadband responded. In the health context, it's even more acute in some sense, because while we are happy saying it is of sufficient quality, like Dr. Raja was saying in the morning panel, where is the measurement for that quality? Who is actually seeing what it is doing to, let's say, infectious diseases or for antibiotic resistance? Because now the private makers have accommodated this new normal that they're going to live in. So I feel, yes, potentially this is an equilibrium level of quality, but we need data to show what's happening to health outcomes pre and post such change in the equilibrium in the markets. And it's not easy to get those data. I forgot to tell this in the morning that, for example, health insurance claims data are so difficult to obtain, public or private, in the Indian context. That would have given us like simple measures, length of stay. Is there a repeat visit by the patient after taking a medicine from the public pharmacy program versus the private shops for the same drug molecule? We don't have that information. And we know how our politicians use these interventions to earn cheap and fast political incentives. So that's my biggest trade-off concern. It might on the margin increase access for today's compromise on quality of healthcare. But in the long run, is this the way forward in a conversation around value and volume, like Samarth was rightly saying? I'm unsure. We need data to have a conversation, an evidence-based conversation on that. Otherwise, we'll again become a policy-based evidence conversation.
So in the context of that, one thing just occurred to me that this whole access to medicine thing, this is where Nina's paper is very important.
Yes.
In order to cut down on prices, eventually there is actually a negative effect. I mean, unexpected consequences. So these are very important takeaways for policymakers. Do we have any other comments, or other ways we will call it a day here? All right, so it was a great pleasure to have you here. Thanks for joining us. Thank you, Chirantan. The only thing that I envy here is your background. Yeah. For quite some time, I've been saying that you are singing on a series, enjoying yourself. So we will, end the session here, and
this is
a small, token of appreciation. Someone I'd like to invite you to the stage. Sorry, Kiran, you were saying?
I was saying this is the peril of being at Sussex by the sea. So, but thanks, Nina, for making time from Beijing, and also Bigel is now gone. Samar, thanks for flying over from Ahmedabad, and I really enjoyed the conversation and hope the audience also loved it. Anindya, much appreciate your co-moderation job. Thanks, Nina. Now I think we'll have some music again. We have a very Bollywood style conference here going on.
I would like to thank everyone for attending today's conference. Hope you all have enjoyed all the sessions and gained some valuable insights. We'll be meeting again tomorrow. Thank you all.
Thank you. Good night, Nina. Bye-bye.